Good afternoon. This is Sarah Hershey from the New York State Department of Health, and this is our webinar, What's New with the Flu, COVID, and RSV2 2025-2026. I am the Adult Immunization Coordinator with the New York State Department of Health. Let's get started. We'll start off today with our agenda. First will be an overview of the 2024-2025 influenza season, followed by some slides showing you our updated New York State Department of Health respiratory surveillance report, and some COVID and RSV disease surveillance data, and the 2024-2025 influenza, COVID, and RSV vaccine effectiveness and vaccination coverage, followed by this year the 2025-2026 recommendations for influenza, COVID-19, and RSV vaccines, some New York State COVID resources, New York State influenza vaccine requirements, and rounding it out with influenza vaccination coverage for healthcare personnel. So starting off with the influenza 2024-2025 season. This is the CDC's burden of influenza disease for the 24-25 season since October 1st, 2024. They estimate there has been 47 million, between 47 million and 82 million flu illnesses, 21 million to 37 million flu medical visits, 610,000 to 1.3 million flu hospitalizations, 27,130 flu deaths. Here's some New York State specific data. This is looking at positive influenza cases by season, and you can see 4 seasons here, with the red being the 24-25 season, green the 23-24 season, brown the 22-23 season, and the blue being the 21-22 season. As you can see here, the red line showing the 24-25 season shows a more severe season and a little longer duration than the 22-23 season, and also more severe than the 23-24 season. Severity of the 24-25 influenza season is available on the flu view for the CDC at the link at the bottom of this slide. And their preliminary severity assessment for the 24-25 influenza season that was reported on May 23rd shows a high severity with the following indicators high across all age groups: the rates of influenza-like illness, rates of hospitalizations, and rates of influenza deaths. As of the week ending September 19th, 280 pediatric deaths have been reported to the CDC for last year's influenza season, and this is the highest number of reported pediatric influenza-related deaths in a non-pandemic influenza season since influenza-associated pediatric deaths became reportable in 2004. Here we see for New York State the incidence of positive influenza laboratory results by region, with the metro area and New York City having the highest incidence per 100,000 persons, followed by central, western, and then capital districts. Here we see the positive influenza tests reported by flu type, with the orange being influenza AH1, the maroon being influenza AH3, the yellow being influenza A subtype not performed, the green as influenza B Victoria, the blue is influenza B lineage not determined, and the dotted line is the percent positive. So as we can see here, we did have a predominant influenza A season. Here we have a pie chart showing laboratory confirmed influenza by age. And as we can see, the 18 to 49-year-olds and the 5 to 17-year-olds have more than half of the laboratory confirmed influenza for the 24-25 season. Hospitalizations with influenza cases are shown here for the last 4 seasons, with the red again being 24-25, green 23-24, brown 22-23, and blue being a 21-22 season. So here again, we do see a higher severity than the previous 3 seasons, and that it was a longer lasting influenza season. This is showing patients hospitalized with lab-confirmed influenza by region and by age. So each column is by region, and the colors within that are for specific age groups, beginning with the blue as 0 to 4 years of age and the orange being 75 plus. And we can see here that for all regions, the 75 plus had the most number of hospitalizations, followed by the 65 to 74-year-olds. This is the incidence of hospitalizations by region per 100,000 persons, with the metro area and New York City having the highest incidence, followed by Central, then the Capital District, and then the Western region. Here we see persons who are hospitalized with lab-confirmed influenza, showing that by underlying medical condition. The purple are adults. The dark blue is females, and we see that for the line labeled pregnancy. The orange is for pediatrics, and the light blue is for pediatrics 0 to 2 years old, shown here for the line for prematurity. So for adults, we see cardiovascular disease, hypertension, and chronic lung disease as being the top 3 underlying medical conditions. For children, we do see here asthma, but we do see the largest bar here is for children with no known underlying medical condition, and that made up 42% of cases. This one shows positive RSV, influenza, and COVID results through week ending August 9th, 2025, showing it over a 12-month span. And we do see here very definitive peaks for both flu and RSV, but that COVID kind of went up and down throughout the year. Now I'll show you our updated New York State Department of Health Respiratory Surveillance Report. So in previous years, this was an influenza surveillance report. So when you would look up the most recent, most current report at the link on this slide, this is what you would see at the top of the surveillance report. And this year, this has been changed to a respiratory surveillance report. So this will include influenza in blue, COVID in orange, and RSV in green. And as you scroll down through the surveillance reports for this season, those colors will remain. So in graphs and in other things, influenza numbers will be represented in blue, COVID in orange, and RSV in green. And those are available, again, at the slide at the bottom, at the link at the bottom of this slide. Moving on to COVID-19 cases, there was a press release on November 4th. You can access that either by the QR code on the screen or by the link at the bottom of the slide. Vaccination uptake remains low. Statewide COVID vaccinations are down 30% versus the same period in 2024, and adults 65 and older doses are down by 25%. So what's the clinical impact? COVID continues to cause more severe outcomes than flu. In 2024, there were 2,775 COVID deaths versus 766 for flu, and 50,000 plus COVID hospitalizations versus 21,000 for flu. There's an urgent need ahead of the upcoming holidays, with increased indoor gatherings and travel expected, and updated vaccination remains the best protection against severe illness and death from COVID-19 disease. This is taken from the New York State Department of Health website at the link at the bottom of the slide. And with this data, you can look at it by time period, region, or county. I have selected to show you the last 12 months, showing all regions and all counties. And as you can see, this starts in November 2024 and goes until the last date updated for this particular slide was October 22nd, 2025. And as you can see, there were higher numbers of cases in December, January, February, March, and then started going down in April and May. And then we saw another peak in August, September, October here in New York State. And then this is national data from the COVID-Net at CDC's website. And as you can see, they had some similar peaks during the similar timeframes for the 24-25 season. Moving on to RSV cases, this is also taken from the CDC website at the RSV Net link added on this slide. And then you can see that in the 24-25, the RSV season was primarily December, January, February, and then falling off in March and spring. Moving on to interim influenza vaccine effectiveness estimates for the 24-25 season. So this is the vaccine effectiveness October 2024 through February 2025. This one shows for all ages and any types of influenza. The Vision Network showed for outpatients a 56% effectiveness, and the U.S. Flu Vaccine Effectiveness Network showed 42%. This is looking particularly at children under 18 years of age. Starting off first for any type of influenza, the NVSN for outpatient showed a 59% effectiveness. The U.S. Flu Vaccine Effectiveness Network showed a 32%, and the Vision Network showed a 60% vaccine effectiveness. For inpatient, the NVSN network showed a 63% vaccine effectiveness, and Vision showed 78%. Looking at specific type of influenza, for H1N1, the outpatient numbers were 72 and 53%, and the inpatient number was 63%. For H3N2, the outpatient in NVSN was 42%. However, the U.S. Flu Vaccine Effectiveness Network's number was not statistically significant, as the confidence interval includes 0. And the NVSN inpatient vaccine effectiveness was shown to be 55%. Looking at adults 18 years and older, for any influenza, the outpatient networks showed 36% and 54%. The inpatient network showed 41% and 55%. Specifically for H1N1, the U.S. flu vaccine effectiveness showed for outpatient effectiveness of 42%. However, the IV for inpatient, the number was not statistically significant, as the confidence interval includes 0. The same for U.S. flu vaccine effectiveness for outpatient for H3N2 was also not statistically significant, but in the IV for inpatient, they did find a 51% vaccine effectiveness. For adults 18 to 64 years of age, for any influenza, outpatient showed a 37 and 56% vaccine effectiveness, and inpatient 48 and 51%. For adults age 65 and older for any influenza, outpatient in the U.S. flu vaccine effectiveness network was not statistically significant, but the Vision network was 51%. And for inpatient, there was a 38% and 57% vaccine effectiveness found. Moving on to COVID-19 vaccine effectiveness as presented by the CDC at the September 19th, 2025 ACIP meeting. This is looking at emergency department and urgent care encounters in the Vision network. For 9 months to 4 years, they found a 79% vaccine effectiveness. 5 to 17 years, a 57% vaccine effectiveness, and 18 years and older, a 34% vaccine effectiveness. Looking at vaccine effectiveness for emergency department and urgent care encounters among immunocompetent women by pregnancy status from the Vision network. For women who were pregnant, they found a 58% vaccine effectiveness, and for not pregnant women, they found a 37% vaccine effectiveness. This looks at the effectiveness of maternal vaccination and the prevention of COVID-19 associated hospitalizations among infants. So mom was vaccinated, and this was how effective was the vaccine in protecting those children at the tender infants prior to them being old enough to be vaccinated. So the 0 to 5 months, we see 35%. And when they looked specifically at the 0 to 2 months, they found a 54% vaccine effectiveness when the mom had been vaccinated during pregnancy. This is looking at hospitalization among immunocompetent adults age 65 and older, first in the Vision network. And it also looks at days prior that the vaccine was given prior to hospitalization. So starting at 7 to 179 days earlier, we see a 44% vaccine effectiveness. 7 to 59 days earlier, 46%. 60 to 119 days earlier, 50%, and 120 to 179 days earlier, 32%. In the IV network, they use the same day ranges, and we see vaccine effectiveness between 40% and 53%. Looking at critical illness among immunocompetent adults 65 years and older, the Vision used the same days earlier than the critical illness as when the vaccine was received, and vaccine effectiveness ranging from 43% to 46%. The IV network looked at specific critical illness outcomes, with the first one being acute respiratory failure, finding a 44% vaccine effectiveness. Effectiveness against ICU admission or death was seen to be 56% effective, and effectiveness against invasive mechanical ventilation or death was found to be 70% effective. Looking at 24-25 data for hospitalizations among immunocompromised adults aged 65 years and older. In the Vision network, again, they looked at the different days prior to hospitalization that the vaccine was given, and they saw a range of 25 to 47% vaccine effectiveness. And in the IV, they just looked at 7 to 179 days earlier and found a 36% vaccine effectiveness. So these were the conclusions presented at the September ACIP meeting. For the respective years shown, either 2023 or 2024, or the 24-25 season, compared to no in-season dose, COVID-19 vaccination provide additional protection against COVID-19 associated emergency department or urgent care visits among children, and protection was similar across age groups. Showed protection against emergency department and urgent care visits among adults, protection against hospitalizations among adults aged 65 years and older with and without immunocompromising conditions, and against critical illness among adults aged 65 years and older. And the protection appeared to be higher and more durable against critical illness compared to less severe outcomes. Vaccine effectiveness should be interpreted as the added benefit of 23-24 or 24-25 COVID-19 vaccination in a population with high levels of infection-induced immunity, vaccine-induced immunity, or both. Prior SARS-CoV-2 infection contributes protection against future disease, though protection does wane over time. An increase in SARS-CoV-2 circulation in the United States during late summer 2024, just before the 24-25 COVID-19 vaccines were approved and authorized, may have resulted in higher population-level immunity against the JN.1 lineage strains, which could have resulted in lower measured VE than in a population with less recent infection. Moving on to the vaccine effectiveness for the 24-25 season. The RSV vaccine effectiveness for 24-25 season was presented at the June 25th, 2025 ACIP meeting. And this is a summary of the prevention product among infants in their first RSV season, the 24-25 season. The RSV associated emergency department visits, nirsevimab showed a effectiveness of 63% in the Vision network and 76% in the NVSN network. And maternal vaccine in the Vision network showed a 54% vaccine effectiveness. RSV-associated hospitalizations, nirsevimab showed in the Vision a 79% effectiveness, and the NVSN an 82% effectiveness, and this is similar to in clinical trials where they found an 81% effectiveness. Maternal vaccination showed effectiveness against RSV-associated hospitalizations in the Vision network, a 79% vaccine effectiveness, and the NVSN showed a 70% vaccine effectiveness, which were both higher than the clinical trial, which showed a 57% vaccine effectiveness. And then effectiveness against RSV-associated intensive care unit, or ICU admissions. Nirsevimab showed in the Vision network an 82% effectiveness, the NVSN network an 88% effectiveness, and the Overcoming network an 80% effectiveness. These are lower than the clinical trial, which found a 90% effectiveness, yet these are still very high effectiveness numbers. So product effectiveness conclusions that were presented at the meeting include that nirsevimab was effective against RSV-associated emergency department encounters, hospitalizations, and critical illness among infants in their first RSV season during the 2024-2025 RSV season in the United States. Maternal vaccination was effective against RSV-associated emergency department encounters and hospitalizations during the 2024-2025 RSV season in the United States. And ongoing monitoring of post-licensure nirsevimab and maternal RSV vaccine effectiveness will be necessary to assess additional outcomes. Looking at RSV vaccine effectiveness for adults, there was a study that was published in the Clinical Infectious Disease Journal looking at vaccine effectiveness for those 60 years of age from the first post-licensure season. Overall, vaccine effectiveness for emergency department visits and hospitalizations was 92%. Vaccine effectiveness for patients with high-risk conditions was also 92%. Vaccine effectiveness against critical outcomes was 90%, and vaccine effectiveness against severe disease was 92%. Now we're going to move on to vaccination coverage estimates. So here are the influenza vaccination coverage estimates for the 2024-2025 season. Influenza vaccination coverage among children as of April 26th, 2025 are 4.2% below the same time last season at 49.2% compared with 53.9%. Coverage estimates for all adults as of April 26, 2025 are similar to those from the previous season at 46.7% compared with 47.4%. Coverage estimates for pregnant persons as of March 29, 2025 are also similar to the previous season at 38.0% compared to 38.1%. And coverage estimates for adults 65 years and older who are Medicare fee-for-service beneficiaries as of February 22, 2025 were at 48.3%. But coverage from February 2024 for 65 years in age and older were 66.2% in CDC's FluVax view, and that link is here on this slide. This is taken from the CDC FluVax view, and here we see we've got 6 different flu seasons represented, and this is showing coverage for children 6 months through 17 years. And as we see, the yellow line being 2019, 2020, and the red line 2024, that there has been a slight decline each year in coverage for children, but that all 6 of these seasons have fallen below the healthy people target of 70%. This is looking at pregnant women ages 18 to 49, and we also have the same 6 seasons shown here, with the red line being 2024-25 and the light green being 2019-2020. And we see similar decrease in coverage, although coverage is a little higher, but still all of these were under 60%, with 24-25 coverage being below 40%. This is looking at coverage for adults 18 years and older for the previous 2 seasons, 2024-25 and 2023-2024. And we see here we have similar coverage for both seasons, but well below that healthy people target of 70%. This is showing for Medicare fee-for-service beneficiaries age 65 years and older, again, 6 Seasons shown here a little bit tighter, not quite as much of a decline, but we do see the 2024-2025 season did have lower coverage than previous seasons, and that all of them were below 60%, with the 24-25 season showing to be below 50%. Next, we'll move on to COVID vaccination coverage estimates for 2024-2025. This one shows, these numbers were as presented by the CDC during the June 25th ACIP meeting. And this first slide shows adults 18 years and older and adults 65 years and older. So for all adults 18 years and older, coverage was 23%, and coverage for 65 years and older was 44.1%. This is broken down further by age group, with all age 18 years and older at the 23%, like we saw on the previous slide, similar to the previous season numbers. For the 65 to 74-year-olds, we could see nationally a slight increase from 37.9% to 42.7%. And for 75 and older, we saw an increase of 38.3% to 46.5%. This is showing coverage for among children 6 months to 17 years. So you can see all of these numbers are quite low, with the lowest being in that 6 months to 4 years of age. In summary, the COVID-19 vaccination coverage for older adults improved in 2024-2025 compared to the previous season, but vaccination coverage for all adults 18 years and older was similar between the two seasons. Approximately 13% of children between 6 months and 17 years of age were up to date with COVID vaccination at the end of April 2025. RSV vaccination coverage estimates for 24-25 season. This is taken from the RSV VaxView on CDC's webpage, showing 75 years plus coverage. And the 75 years plus coverage is 47.5%. And although not shown here on this slide, there is also a coverage for 60 to 74 years of age, and that was 31.8% as of April 19th, 2025. And these numbers can be seen at the link at the bottom of this slide. Moving on to the recommendations for influenza vaccine for the 2025-2026 influenza season. Influenza vaccine continues to be recommended for everyone 6 months and older. New for the 25-26 influenza season, FluMist has been approved for self-administration by people 18 years and older, and for administration by a caregiver who is 18 years and older for children who are 2 to 17 years of age. The Food and Drug Administration expanded the approval for Flublok down to 9 years of age, and Flublok was previously approved for people 18 years and older. The Advisory Committee on Immunization Practices made a recommendation for children, pregnant persons, and adults to receive only influenza vaccine in single-dose preparations that are free from thimerosal. Due to this recommendation, there is no Afluria presentation for children 6 to 35 months of age. This is because the dose for that age is 0.25 mLs, and single-dose presentations are only available in the 0.5 ml dose. Children 6 to 35 months of age can receive one of the other 4 vaccines approved for their age and available in single-dose preparations. These are some reminders of recommendations that were updated in recent influenza seasons. There is a preferential recommendation for persons 65 years and older to receive either the high dose, the recombinant, or adjuvanted influenza vaccine. However, important to mention that if that is not available at the time of vaccination and you're not sure you'll see the person back again, they can receive any age-appropriate vaccine. Off-label recommendation for persons aged 18 to 64 years who are solid organ transplant recipients can receive either the high dose or adjuvanted vaccine. However, this is not a preferential recommendation over age-appropriate influenza vaccines. This is just an additional choice. Here shows the influenza vaccine composition for the 25-26 vaccine. Then the one in red shows a change from the 24-25 vaccine, and that is for the H3N2 strain. The H1N1 strain and the B Victoria strain are the same as last season's influenza vaccine. Moving on to the COVID vaccine recommendations for 2025-2026. First, we will begin with the available vaccines, and on these slides for each of these vaccines, you see the FDA link here where you can get the full prescribing information. Moderna's Spikevax is an mRNA vaccine approved for those 65 years and older, or 6 months to 64 years with at least one underlying condition putting them at high risk for severe outcomes from COVID-19. The next spike is also an mRNA vaccine by Moderna and is also approved for those 65 years and older, or for 12 years to 64 years with at least one underlying condition, putting them at increased risk for severe outcomes from COVID-19. The Pfizer vaccine is also an mRNA vaccine approved for those 65 years and older, or 5 years to 64 years with at least one underlying condition, putting them at high risk for severe outcomes from COVID-19. Novavax is a protein subunit vaccine approved for those 65 years and older, or 12 years to 64 years with at least one underlying condition, putting them at high risk for severe outcomes from COVID-19. First, we will look at the CDC's updated COVID-19 vaccine recommendations. These are for those under 65 years of age, one or more doses for those under 65 years with vaccination based on individual-based decision-making, with an emphasis that the risk-benefit of vaccination is most favorable for individuals who are at an increased risk for severe COVID-19 disease, and lowest for individuals who are not at an increased risk, according to the CDC list of COVID-19 risk factors. And here you can see an excerpt from the updated clinical considerations for those under 65 that are available at the link on this slide. For those 65 years and older, 2 or more doses for those 65 years and older with the second dose of the 2025-2026 COVID vaccine given 6 months after the first dose. Vaccination, again, based on individual-based decision-making with an emphasis that the risk-benefit of vaccination is most favorable for individuals who are at an increased risk for severe COVID-19 disease and lowest for individuals who are not at an increased risk, according to the CDC list of COVID-19 risk factors. And again, there is an excerpt here of the 65 years and older recommendations. For those who are immunocompromised and 6 months of age and older, if they have completed the initial series before the 25-26 season, they should receive 2 doses of 25-26 vaccines spaced 6 months apart. Immunocompromised individuals 6 months and older who have not received a COVID vaccine prior to 2025-2026 season should receive the initial 3-dose series, then a 4th dose 6 months after dose 3. Additional doses are no longer recommended beyond the doses mentioned in the first 2 bullets. Further dosing information for immunocompromised individuals can be found in the link at the bottom of this slide. CDC updated their immunization schedules in the child and adolescent schedule to say vaccination is based on individual-based decision-making, with an emphasis that the risk-benefit of vaccination is most favorable for individuals who are at an increased risk for severe COVID-19 disease and lowest for individuals who are not at an increased risk, according to the CDC list of COVID-19 risk factors. And there is a link of high-risk underlying conditions that is available at the link here. Due to these updates to the CDC and ACIP recommendations, the American Academy of Pediatrics, as well as other medical associations, have released their own recommendations. So the American Academy of Pediatrics released a full childhood immunization schedule that includes updates to the influenza, RSV, and COVID vaccines. And they are available at the link here at the first bullet. The American College of Obstetrician and Gynecologists updated their guidance for COVID, influenza, and RSV vaccines and are available at the link at the second bullet. The American Academy of Family Physicians released guidance for COVID, RSV, and influenza vaccines and are available at the third bullet. The American College of Cardiology released guidance for influenza, pneumococcal, COVID, RSV, and shingles vaccines and are available at the link on this first bullet. The Infectious Diseases Society of America released guidelines for COVID vaccines for people who are immunocompromised, and those guidelines are available at the link at the second bullet. America's health insurance plans announced that health plans will continue to cover all ACIP recommended immunizations that were recommended as of September 1, 2025, including updated formulations of the COVID-19 and influenza vaccines with no cost sharing for patients through the end of 2026. The announcement is available at the link at the as part of this third bullet. And then there's some New York State COVID resources to share with you. The Executive Order 52 authorizes pharmacists to prescribe patient-specific COVID-19 vaccinations to individuals 3 years or older. This executive order has been renewed 3 times, with the new expiration date being December 25th, and the link is here for the most current executive order. It also authorizes pharmacists to administer non-patient specific COVID-19 vaccinations via standing orders. This authorizes pharmacists to administer COVID-19 vaccines for individuals outside of the standing order indications, which can allow them to include those who aren't at high risk. And there were also standing orders signed by Commissioner McDonald for pharmacists, and they have been posted at the link provided here at this bottom bullet. Several guidance documents have also been provided by the New York State Department of Health and are available at the link at this first bullet. And recommendations have been made in collaboration with the Northeast Public Health Collaborative of 7 states and New York City. And there was a press release about the collaborative, and that is available here at the link in the middle of this slide. And at the link at the top of the slide, you will find guidance for COVID guidance for children, guidance for pregnant people, guidance for adults, and guidance for pharmacists. There are some social media posts on RSV, flu, and COVID. Here we see one, and I'll let that play through so that you can see the whole slide. And the point of this slide is that although there are age groups that have quite the burden of influenza and RSV, we're still seeing a higher burden of COVID disease. And then here are some of the posts on Instagram, LinkedIn, and Twitter. Moving on to the RSV vaccine recommendations. So first we'll talk about the monoclonal antibody immunization for RSV for infants, and those are Beyfortus, nirsevimab, and influenza, the clesrovimab. Infants less than 8 months who are born or entering their first RSV season. If the mother did not receive RSV vaccine or the vaccine status is unknown, the baby should be administered 1 dose within 1 week of birth, ideally during birth hospitalization. If the mother received RSV vaccine less than 14 days before birth, then 1 dose should be administered within 1 week of birth, ideally during the birth hospitalization. If the mother received RSV vaccine at least 14 days prior to birth, monoclonal antibody is not needed, but can be considered in rare circumstances at the discretion of the healthcare provider. And this was taken from the American Academy of Pediatric Immunization Schedule, and the PDF is linked on this slide. Continuing on, for infants who are 8 to 19 months of age in high-risk categories, 1 dose should be given before the start of their second RSV season. And high-risk categories include chronic lung disease of prematurity that requires medical support, severe immunocompromise, cystic fibrosis with less than 10th percentile weight for length or severe lung disease, and American Indian or Alaska Native status. Looking at RSV vaccine recommendations for adults, adults 75 years of age and older should receive a single dose of RSV vaccine. Adults 50 to 74 years of age and older who are at an increased risk of severe RSV disease should receive a single dose of RSV vaccine. Pregnant people at 32 weeks and 0 days through 36 weeks and 6 days gestation from September through January in most of the continental U.S. should receive 1 dose of a RSV vaccine, which is the only RSV vaccine approved and recommended during pregnancy. The RSV vaccination is recommended as a single lifetime dose only. Persons who have already received RSV vaccination are not recommended to receive another dose at this time. And these recommendations supplant the current recommendations that adults 60 years of age and older may receive RSV vaccination using shared clinical decision-making. Adults 50 to 74 years of age who are not at increased risk of severe RSV disease are not recommended to receive RSV vaccine. And these are the list of underlying medical conditions that would put people at an increased risk of severe RSV disease, and they are available in the MMWR that is linked at the bottom of this slide. All right, looking at New York State specific vaccine requirements. This is a list of the ones that I'm going to review today, and I'm going to be reading off my papers here so that I make sure I get all of the verbiage correct, as these are legal regulations and laws. So number one, pharmacists as immunizers under New York State education law, they are authorized to administer influenza vaccine to those 2 years of age and older. They are under the executive order, they can give COVID vaccine to 3 years of age and older. And then for all other vaccines that they are authorized for, it is for 18 years and older. The second bullet, we have the New York State Public Health Law, Section 2112. This prohibits the administration of vaccines containing more than 1.25 micrograms of mercury per 0.5 ml to women who know they are pregnant, or 0.625 micrograms of mercury per 0.25 mLs to children 3 years of age and older. All single-dose vials and pre-filled syringes of influenza vaccine are thimerosal-free. Only multi-dose vials have thimerosal, and per the ACIP and CDC recommendation, they had recommended no thimerosal vaccine be given to any child, pregnant person, or adult. So this is not as likely to be an issue for this season. We do also put out a vaccine supply determination, and it has been determined that there should be an adequate supply of vaccine that does comply with this public health law. New York State Public Health Law, Section 2805-H, requires nursing homes, adult homes, enriched housing programs, and adult day health programs to document influenza and pneumococcal vaccination status of all residents by November 30th of each year. Require documentation of influenza and pneumococcal vaccination status of all employees by November 30th each year. Annually provide or arrange for influenza vaccine for all residents and employees found to be lacking documentation of vaccination. Provide or arrange for pneumococcal vaccine for all residents and employees for whom it is recommended and who are lacking documentation. However, no resident or employee shall be required to receive either influenza or pneumococcal vaccine if it is medically contraindicated against his or her religious beliefs, or if they refuse such vaccine after being fully informed of the health risks of such action. And then the last bullet here are regulation for prevention of influenza transmission by healthcare and residential facility and agency personnel, also known as the flu mask regulation, requires that healthcare facilities that are Article 28, 36, or 40 to annually document the influenza vaccination status for all personnel employed by or affiliated with the facility or agency, whether they are paid or unpaid, who engage in activities such that if they became infected with influenza, they could potentially expose patients or residents to the disease. During the influenza season, they need to ensure that all personnel not vaccinated against influenza for the current season wear a surgical or procedural mask while in areas where patients or residents may be present. The New York State Department of Health annually sends out notifications when influenza is prevalent, and posted at the link at the bottom of this slide for this last bullet. And that determination has been made that flu is prevalent across New York State. So any personnel who have not been vaccinated against flu need to wear a surgical or procedural mask when in areas where patients or residents may be present. This is a little more information about the Public Health Law Section 2112 about thimerosal. The vaccine supply declaration was sent and is available here at this QR code, stating that it does appear there will be an adequate supply. Therefore, healthcare providers vaccinating pregnant women and children should seek out and administer a vaccine that complies with Public Health Law 2112, which is single-dose vials and pre-filled syringes. Again, this is probably not going to be a difficulty this year with the ACIP and CDC recommendation for all vaccine to be thimerosal-free for flu vaccine doses. We do, though, want to talk a little bit about thimerosal and vaccine safety. Methyl mercury can be found in certain fish and is toxic to humans at high doses. However, thimerosal contains ethyl mercury, which is rapidly cleared from the human body and does not build up to harmful levels. Thimerosal was removed from all childhood vaccines aside from multi-dose vials of influenza vaccine in 2001. Multiple well-conducted studies have failed to find a causative link between thimerosal-containing vaccines and autism or other safety concerns. Rates of autism continued to rise after thimerosal was removed from vaccines. Now, looking at influenza vaccination coverage for healthcare personnel. This is showing the coverage rates for the influenza seasons 2017, 2018 through 23, 24. And as you can see from most facility types here, we started seeing a decline in the 2020-2021 season, and some continued a decline after that. Some have gone up a little bit, but not to pre-pandemic coverage rates. Although this survey is not powered to show intent of vaccination, the initial drops here were during the time of COVID mask mandates. So why is it important for influenza vaccination for healthcare personnel? Healthcare personnel professionals are trusted messengers for health information, including influenza vaccine. Healthcare professionals should lead by example and receive the influenza vaccine each year. Influenza vaccination is important for patient safety, as healthcare personnel infected with influenza can spread the virus to vulnerable patients, residents, and coworkers. Annual influenza vaccination of healthcare personnel offers several benefits, including prevention of severe illness and deaths, protection for those they come in contact with, including patients, residents, coworkers, and family members, and can decrease the use of sick time. Even healthy people can get severely sick with influenza, but those at highest risk include infants and children younger than 5 years, adults 65 years and older, pregnant women, those with certain medical conditions, and specific racial and ethnic groups. Here are some resources for influenza vaccination of healthcare workers, including one from the National Foundation for Infectious Diseases, the National Adult and Influenza Immunization Summit, the Centers for Disease Control and Prevention, and the Occupational Safety and Health Administration. That is the end of our content for this webinar. There were some questions that did come up during our live webinar. And so I am going to stop sharing now, and I'm going to look at some of those, and I wanted to be able to read those questions and what our responses were during that, so that those that listen to the recording have the benefit of those as well. So there was someone asked about thoughts on Tamiflu usage. Yes, influenza vaccine and combined with antivirals for flu as soon as symptoms occur, as soon as possible, offer the best protection from severe illness. There was a question about health insurance covering the COVID vaccine. if they don't have a pre-existing condition. As previously stated, the Health Insurance Association did mention that many health plans will be covering this, but this may not include all of them. And so it is important that each individual person reaches out to their health insurance, because there are many health plans, and then within those health plans, there can be many different group packages and such that may cover some things and may not cover others. So it's important to call your insurance to see if they will cover the COVID vaccine. There was a question about what's the difference between the two Moderna vaccines. The new one, the mRNA spike, works on a very small part of the spike protein, which allows it to be a smaller dose. It is a newer vaccine, and it's also important to remember that the Spikevax is available down to 6 months of age, but that the mRNA spike is down to 12 years of age. There's a question about confirming up to date with CDC guidance for adults 65 and older when they have 2025-2026 COVID vaccine. If they had only one and it's not yet time for the second, are they considered up to date? And the answer there would be yes. According to the CDC guidance, yes. The first dose should be given, and then the second dose 6 months later, so that would make them up to date. They were asking if there was a high dose flu available for 65 and older who are uninsured. The New York State Department of Health does have a Vaccines for Adults program. That is a state program where the VFC program, Vaccines for Children, is a federal program, and influenza vaccines are included in that. And there is an email that you can inquire about that. It is nyvfc@health.ny.gov. You can also check with your local health department as well to see if there's a VFA provider in your area. So either one, your local health department or that email, nyvfc@health.ny.gov. There was also a question looking for clarity that the COVID vaccine is no longer considered a booster, but rather an annual vaccine. So yes, they are not being labeled as boosters. However, COVID hasn't really developed a seasonality like the flu and the RSV vaccine. So as of right now, there is an annually updated vaccine with annually updated recommendations for the use of the vaccine, but to say that that's what will go moving forward, not really there to be able to say that yet, as like there has not been a distinct seasonality shown for COVID vaccine. And that was the questions that we received during the webinar. So that will end this recording. And if you have questions for us, please feel free to email us at immunize@health.ny.gov. IMMUNIZE@HEALTH.ny.gov. Thank you very much, and I hope you have a great day.